that's the temporal space, like post-infectious. Just think about it that way. After the infection, way after the infection. 7 days to a month after, okay? Gonna seem similar, but they're gonna have a, that temporal thing clinically is how you really distinguish it, and then the labs and all that and so on and so forth, okay? Good. Huh? Delta, yeah. Dark colored urine, right? Blood in the urine, right? Bloody urine, yeah, right? Ascites, no. What's ascites go with? Nephrotic syndrome. Yeah. Yes, third spacing. Liver, you're right, absolutely, you are correct. Right. But in this case, we're in the kidney class, right? Yeah, so nephrotic syndrome. Frothy urine, what does that go with? Proteinuria, which goes with nephrotic syndrome. Stupor, well, we're all kind of in that right now. Pneumonia, what does pneumonia go with if you walk the dog a little bit? Nephrotic syndrome, because of third spacing of fluid sitting there in your lungs as well, causing potentially pneumonia. All right, so dark colored urine, like that is going to be like what somebody's going to say. The patients aren't always going to say, and I have bloody urine. And my urine is dark, okay? So, got it. Little thought. Post-infectious glomerulonephritis. What did I say the other term for it used to be? Post-streptococcal glomerulonephritis, right? So which one might be useful? C, the ASO titer, anti-streptolizin O titer might be useful if the patient has an untreated or undertreated, right? Everything else isn't going to confirm anything, right? Yeah, your analysis and CMP are going to be useful, but they're not going to confirm anything. They're just going to tell you that you have nephritic findings, right? Doesn't really tell you. It could be anything, anything on the spectrum of glomerulonephritis. Does that make sense? So read. Words are important. Confirming the diagnosis of it, right? Plasmapheresis, otherwise known maybe as therapeutic plasma exchange. Which one? You say TTP? Somebody said that's true, but that's not an answer. Okay. Which one? Good pasture. Good pasture. And what are we trying to get out by doing that plasma exchange? Anti-GBM antibodies. That is correct. Think about this one. This one's stupidly tricky for no reason other than amusement. Serum albumin below 2 grams places a patient at greatest risk of what? What is the risk when they have severe hypoalbuminemia? Thrombosis. Right? Why? Because of severe hemoconcentration, right? That's probably a part of the nephrotic syndrome. They're not at risk of nephrotic syndrome. They're at risk of thrombosis. Okay? I told you it's dumb, it's tricky, but just to tie that point together, okay? Glomerulosclerosis, renal infarction, not really, we talked about that today. Renal infarction, that's more on the arterial side. That's more a bit of somebody who has, say, atrial fibrillation is a common setup for renal infarction. Okay, renal vein thrombosis, now that is the answer, right? So thrombosis and purpura, well, that really only goes with one thing we can kind of talk about, which is HSP, right? Which has really nothing to do with albumin. It has to do with IgA, vasculitis. So it's a nephritic syndrome, right? Got it? Not associated, we hate negative stim questions, but sometimes, which one does not go with nephrotic syndrome? RBC-CAS, that is correct, RBC-CAS. Don't confuse. Like I said, a little bit of RBC sprinkled in there, that's fine. RBC-CAS, that's profuse bleeding within the glomerulus, that's glomerulonephritis. So RBC-CAS is correct, okay? Everything else goes with the nephrotic syndrome. VUR, vesicular-ureteral reflux, and obstructive uropathy, what might we see? Both. Both are obstructive processes, so which one might go along with both of those? Hydronephrosis, that's right. Okay? Okay? Interlude. Any questions before we get started? Any questions that are not about emergency medicine? Okay. Fair enough. Today's material should, we're not going to speed through it by any stretch of the imagination, but it should go by fairly quickly because, again, we want to, there's no reason to make this any more nebulous than it already is. So again, primary care perspective is where we're at here. A lot of these are going to end it with referral to somebody, okay? So, renal vascular disease. Have you guys talked about secondary hypertension, I imagine, in cards, right? Other reasons, like what is primary hypertension? Hypertension, essential hypertension, right? The way I describe essential hypertension is it just essentially happens. It's just there, right? Secondary hypertension is a cause of hypertension due to something else. These are secondary hypertensions. Did you discuss renal vascular hypertension at all in cards when you had your discussion about it? Okay. Now, again, we're going to give away the game before we start, but the key takeaway here is this is a very resistant hypertension, so this patient will be resistant to multiple different antihypertensive medications, maybe 2, maybe 3. You cannot get them under control. Oftentimes they will present at weird ages, like very young or very old, right? So let's say younger than 20 typically, or older than 40, right? Essential hypertension kind of presents usually in the middle there, kind of in the middle. That's when normal hypertension kind of shows up, so it doesn't really make a lot of sense. And then there'll be other things. You guys remember listening? No renal, arterial, or femoral bruits, right? Well, in this case, they might have a renal bruit, okay? That is the reason why we do those exams, to see if you can hear an atherosclerotic buildup in the renal arteries, because atherosclerosis is the most common cause of renal vascular hypertension, okay? Not the only, but the most common. So in any case, if you think about the physiology, why, and it's a stupid thing that I've said over and over here, why is an atherosclerotic buildup causing hypertension? Because the RAS is on 11 constantly, right? It's just spitting out ACE to try to clamp down on that efferent arteriole and keep the pressure in the glomerulus, because there is some sort of obstruction to the arteries coming into it, right? So blood flow into the kidney is relatively obstructed by an atherosclerotic plaque or some other malformation of the artery itself. And so it should make sense to you that not enough blood is coming in. The kidney is a notoriously selfish organ. It will turn on the RAS system to 11 so it can keep itself perfused. Does that make sense? Is the basic physiology of what happens. And does that also make sense about why none of our medications will adequately really touch it? Why it's going to be resistant to multiple antihypertensives, right? So if we turn off the ACE, all we're really doing is letting more blood out, but the end pipe, there's still that atherosclerotic plaque. There's still not enough blood getting there. If we give them beta blockers, it doesn't do anything because the end pipe is still blocked, right? Calcium channel blockers, blah, 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 blah. You see what I'm saying? Diuretics don't do anything. Diuretics sometimes even make it worse, right? Because then we have an obstruction. We have a pre-renal, essentially, physiology. Does that make sense to everybody? So constantly, we're not being able to touch this patient for some reason. ACE inhibitor, nothing. Still 150 over whatever. Double the ACE inhibitor, nothing, right? See what I mean? That's what kind of is a giveaway that this may be a secondary etiology for this hypertension. Most primary hypertension should respond, okay, to our antihypertensives, our standards of care. And if it doesn't, something else is going on, right? So, most common is atherosclerosis. You guys are just fresh out of cardiology, so you know the risk factors for atherosclerotic disease. And that's all this is. The patient who has the same cardiac risk factors to develop atherosclerosis has those risk factors to develop renal vascular hypertension. Nothing has changed. Obesity, poor diet, diabetes probably, of course, right? Hypertriglyceridemia, right? Family history, smoking, it's always in there, right? Nothing is different. This could be in the cardiology. This could be a cardiology slide. So there's no reason, it doesn't entice you to commit anything new to memory is what I'm trying to say. That's why I say this bit is a little bit straightforward. Here's one you might not have discussed ever before. So fibromuscular dysplasia. Essentially what you have here is you have alternating areas in the renal vasculature, in this case we're talking about the renal artery, that are alternatively sclerotic and then normal, right? So it narrows, then it gets normal, then it narrows again, then it gets normal, then it narrows again, okay? So what do you have throughout the entirety of the renal artery? Relative sclerosis, right? So the pathway is still narrowed, it's just not due to a plaque. Does that make sense? And those things don't just occur in the renal arteries, they occur throughout the patient's vasculature, all right? When you see, I don't know if you can see this up here, but it says string of beads, string of pearls, something like that is what they usually call it. So what happens is if you get a CTA, what it looks like when the dye goes into the renal artery is a string of pearls. So it looks like a bead and the string and a bead and a string because of that alternating sclerosis and expansion, okay? And really, it's not even necessarily normal. It's more like an alternative of like stenosis and aneurysm. So like pop. So really, that's what it looks like, that beads on a string kind of thing, okay? And again, mean age 52, not really outside of the normal, but again, what gives this one away is that it's resistant. Because again, if you think about it, the net influx, the net flow of blood to the kidney is reduced. So that RAS is on 11, just like with atherosclerotic disease, okay? And then this is typically a female patient. Here, it can involve the carotids and the vertebral arteries, and it also can involve the cerebral arteries. And so sometimes this patient might complain of a pulsatile tinnitus because they can hear that blood whooshing by their eardrum, by their tympanic membrane. Okay. They also have headaches quite a bit. So, the long list, oh my God, doesn't matter, right? What's the most common? Like I just said, headaches, pulsatile tinnitus, and the hypertension. That's what we're talking about, signs, symptoms, okay? The rest of it, right? Really, what's going to give it away? Like I said, it's this patient who you just cannot get their hypertension under control for no apparent obvious reason, okay? And what's going to give it away? All right, so most common things being most common, right? If it looks like a duck and walks like a duck, it must be a duck, right? But not always. So you have this patient working up for hypertension, right? What's probably a good, reasonable part of a hypertension workup? A lipid panel, right? Is that what you said? Yes. Say yes. Yes. Lipid panel, right? A lipid panel. Is this patient going to be hyperlipidemic? Maybe not. Not the fibromuscular dysplasia patient. That's another distinction, right? This patient might not have any risk factors for hyperlipidemia. They might not have hyperlipidemia. This is not your obese, sedentary smoker. This is just a otherwise healthy patient. Okay, now of course if they do have hyperlipidemia, then it clouds the picture. But you see what I'm saying? If you can tease apart the differences here, right? Tease apart the differences, that's something they can tell you. They don't have the risk factors, they don't have the over hyperlipidemia, they still have the symptoms. Maybe it's the 10 instead of the 90. You know what I mean? Yes?
Sir, do they have symptoms throughout their lifetime and age 52 is just kind of when someone gets around to investigate?
No, for some reason the stenosis gets worse over time, so they might present earlier, but most of these patients don't present until later in life as the stenosis becomes more profound. So, any other questions? I'm sorry before I change the slide, but any other questions? Okay. So, again, we have this long, lots of words, so many words, right? What have we already said? Ischemia-induced activation of the renin-angiotensin-aldosterone system. And we know that physiology, we understand it, we've talked about it a lot. We don't have enough blood going to the flowers, they're screaming, they're selfish, as I said. And so they will clamp down the systemic vasculature to make sure that they get fed. And that's what's happening. And that's why we can't control it with regular medications, or one medication, or even two. And then you go down to number 2, over the course of time. That is the mechanism, essentially. Well, let me ask you. Does anybody remember, what would you describe number 2 as? Or can anybody use 2 words to tell me what it would mean? This patient is hypertensive. What's the second word? I love playing guess what I'm thinking. Hypertensive nephropathy. That's the mechanism we talked about yesterday. We talked about diabetic nephropathy and focal segmental glomerulosclerosis. That is renal hyperperfusion that leads to renal overwork, that leads to renal hypertension, and then sclerosis and fibrosis, all right? So, if you look at this, this is just showing you visually, not that it, I think this is a good graphical representation of how much renin is in the stenotic artery. Like your normal amount of renin there, and then how much is increased in the sclerotic artery. And even in the non-sclerotic artery, in the non-sclerotic kidney, I should say, it's still increased. But if you think that a single beta blocker or ACE inhibitor is going to turn this off, there's no way. That visually is why we can't get it under control. Does that make sense? And that's what I mean when I say it's turned on to 11, right? Any Spinal Tap fans in here? Anybody know what I'm talking about? You seen Spinal Tap? Go watch Spinal Tap, and I'll see you in a couple minutes. All right. Anyway, they turn their amplifiers up. Their amplifiers go to 11. It's like a rock mockumentary. Like, well, see, ours go to 11. Why can't you just make 10 louder? No. You see, ours go to 11. It's fucking hilarious, guys. Come on. All right. Anyway. Jeez. All right. So, I'm responsible to multiple antihypertension. So that's what I'm saying. We're not getting it under control. It's the same physiology for both. There's not enough blood going to the kidney. The kidney responds by turning on the RAS system to 11. Yes? You're going to go through your normal process, right? Overtly, this patient isn't ill unless they have like really severe renal disease. Like if you establish that their BUN and creatinine is like super off the chart and they have this really remarkable hypertension, you might start that patient at a higher dose to begin with. But really you're just going to go through your steps of start low and, start low and go slow or whatever, right? So nothing remarkable about this, like, oh man, your hypertension is crazy, but we got to get under control. We'll start you with 20 milligrams of lisinopril, see how it does, right? And then take it from there. So your escalation is probably not going to be any different than the average patient who doesn't have this. You're just going to get to the end point, you're like, I can't do anything for you. And so send them on, you know what I mean? Start to suspect this. Okay? So again, if you say the differences, right? Here's one of the major differences on this one. Risk factors of atherosclerosis. On this side, no risk factors, and then maybe those other weird symptoms. Now, is a person with severe hypertension maybe going to have headaches? Yeah, so that one really doesn't help you differentiate. And the pulsatile tinnitus isn't as common as I make it sound, but it's possible because, again, those aneurysms happen in other arteries. But again, the real difference is the patient in front of you. This one has atherosclerotic risk factors and hyperlipidemia. This one doesn't. So this one over here is the 10, this one's the 90, right? As far as 90-10 solutions go. Other keys, we've already discussed this, okay? This one used to be, if a patient has bilateral renal artery stenosis, then theoretically, if we go to a first line, like an ACE inhibitor, the only thing perfusing those kidneys is ACE, right? Because neither kidney is getting enough blood because there's atherosclerotic plaques in both sides. So the only thing keeping those glomeruli perfused is the ACE because there's not enough blood going to them. If we inhibit that ACE and open the outpipe, then glomerular perfusion drops and you can incite an acute kidney injury through that mechanism. However, the risk of that is pretty damn low, and the benefit of the ACE inhibitor outweighs the theoretical risk. So when we get to this couple slides here, the guideline is still to put these patients on ACE inhibition, all right? Unless they're documented. Like, the only caveat to that is if you got the MRA or the CTA already, you see that they have bilateral disease, then you kind of want to avoid it, okay? So the labs, should they make sense? I hope they do make sense, right? Kidney injury, okay? We're talking about a pre-renal setup that is now causing disease, right? if they have unilateral, which is much more common, unilateral disease, even in the fibromuscular dysplasia, then we might, if we do that renal ultrasound, as we establish hypertension, we might have asymmetric kidney. So one raised and one normal looking kidney. That is a visual representation of chronic kidney disease as well. Okay? And I told you, yeah, this is what we do. Gold standard. No, this is what we actually do. Just like I said in the evaluation of the first lecture. Renal arterial gold standard, that's all fine and good. If that's the only answer on the test, then that's the answer. But most likely, what you're going to do is CTA and MRA, or MRA, pardon me. Okay? And this, I don't know how well you can identify the tortuosity here, but that's that sort of beads on a string. Mardi Gras bead, Jerry bead, you know. So, just the alternating aneurysms and areas of sclerosis, that's what that represents. Okay? And yeah, that's just, this is that on, you know, in a diagram versus the actual radiograph. Now that's only for fibromuscular dysplasia, of course. What is the CTA going to show in an atherosclerotic disease? It's a big bump, right? Probably, or a narrowing of the lumen, depending on how big that plaque is. But it's not going to show these bumps like that. It's just going to show a plaque. Okay. These are just, you know, signs like this is a complete obstruction. That's no good. Severe obstruction here, right? So again, you just see what I'm saying. It's just the hose is kinked. If you think about it that way. So it's not, the water's not getting to them. So they're thirsty. So revascularization is not, revascularization has net worse outcomes. So truthfully, even though there's an acute, like this patient has established hypertension, reversing therapeutic lifestyle changes, unfortunately for atherosclerosis, which is a hard one, right? Then antihyperlipidemics and ACE inhibition is the medical therapy versus like a surgical therapy, stenting or something like that. All right? And again, who makes those decisions? Vascular surgery really makes those decisions, the cardiology, right? But again, approach this medically. If you have renal artery stenosis, you know, depending on the disease cause, again, this would be a good thing to let nephrology take a look at this, maybe cardiology. But primary care management is how we approach the atherosclerotic side, right? If we can reverse that disease and reduce their lipid burden, then we can resolve those plaques, okay? Fibromuscular dysplasia, that person needs a stent because there's no medicine to fix it. They just need it opened up, okay? And this is what I was saying, you know, where are we at here? Good. ACE inhibition, lower risk of death, like it's still the risk. A lot of things we do are that risk-benefit ratio, right? In this case, the benefits greatly outweigh the risk, so we proceed with ACE inhibition. But then what is that incumbent upon you to do? Huh? Monitor. Monitor GFR, monitor BUN creatinine, monitor this patient for a decline in their renal function associated with this new onset medication, right? So maybe this isn't the patient that we give 90 days worth of lisinopril to and say, we'll see you. You know, we give, you know, hey, here, take a month, take 2 weeks, take 3 weeks, come back and see me. Or sooner, of course, if you start to feel better, you know, it's your urine getting dark, you start to have muscle aches and pain, give them the signs and symptoms, bring them back a little sooner, right? It would be more in the active surveillance side. We're going to make sure that they're okay. Once they're on the medicine and they're stable, if their GFR hasn't declined, it's not going to go anywhere. At that point, we can lengthen our follow-up duration or interval. But in the near term, we want to make sure that we're not shutting them down. You know what I mean? Okay. There's a picture for you. Atherosclerosis versus beads on a string. Okay? Either way, the kidney is unhappy. Okay? Any questions about those two? These ones are going to be, yes?
Sorry, I'm trying to comprehend the whole ACE-ARB deciding to go for the ACE first,
Uh-huh.
just in case of risk?
Yeah, unless you have somebody that you know for sure has established bilateral disease, the risk of ACE therapy is outweighed by the benefit of ACE therapy. Yeah.
But avoid ARB for those people.
Oh, ARB same. I mean, I use ACE and ARB interchangeably. You don't want them on both, but one or the other. Like, the only reason you would start somebody on the ACE is if you, or on the ARB, excuse me, is if they fail the ACE inhibition, so.
Okay.
And they're both gonna have, I mean, yes, because angiotensin reception blockade is different, but it's still gonna have a net similar effect to an ACE, so start with the ACE inhibitor and then give them, change them if they develop the cough. You know what I mean? That'd be the real reason.
Yes, sir.
Does that make sense?
Yes.
Sir,
Yeah.
I think it's because we learned that ACE and ARB are an absolute contraindication in immunocytosis or stenosis.
Uh-huh.
So you're saying that if I work a patient out, I'm gonna do these illusion modalities that you said,
Uh-huh.
I will still give it to them unless it's bilateral. If
Yeah.
it's bilateral, then I won't use it in this
Yeah,
case.
and you can always, I mean, you can always, like, if my slide with the research on it, and I don't say that as an arrogance, I mean, I'm saying, this is not my research, I didn't do shit. But like, if you're uncomfortable, always use your consultants. Always defer to using your consultants versus like thinking that you don't wanna bother them. That's what they're there for, all right? So if you get there and you're like, I'm gonna talk to the cardiologist or maybe the nephrologist and say, hey, I got this patient, they have unilateral disease, I want to start them on an ACE. I think the benefits are going to be better for them. What do you think? Do that. Just make a phone call to your consultants if you don't feel 100% comfortable. Or, failing that, refer them on. You know what I mean? But yes, the data has borne out that for somebody with unilateral disease and less than 70% blockage, the data that supports that ACE is beneficial versus risky. You know? Yep. Okay. Couple of quick ones here. So renal infarction, atrial fibrillation, right? One of the sites, those little clots get kicked out. They work their way into the microvascular. One of the places they go, if they don't go up, and they go down. And they get wedged in somewhere, and they kill a part of the kidney. It's the same physiology of anything else, right? It's a stroke in the kidney, okay? And then, here's the rub with this one, or the good thing I should say. Anybody tell me something else related to the kidney that might present with acute flank pain, nausea, pyelonephritis, and kidney stones, right? So, what do you get in order to work up a kidney stone or potentially a pyelo? CT, right? Yes, an ultrasound. Yes, you're right. We love ultrasound, but a CT, right? CT, and we haven't learned about pyelo yet, but a CT is going to show us how bad the pyelo is. If it's emphysematous pyelonephritis, which is really bad, it's going to show us any kind of kidney stone because some of those kidney stones are what? Radiolucent. Yeah, radiolucent. But yeah, so the CT is going to show us all, and that's what else the CT is going to show us. If it's a weirdo like renal infarction or renal thrombosis, okay, right? So this patient's gonna walk in with flank pain and fever. Unless they overtly have atrial fibrillation, you know for some reason they're hypercoagulable or some other reason like something else like that. You're not gonna think about this. This isn't gonna be first on your differential diagnosis. Wouldn't be first on mine. Hell, I'd probably think diverticulitis before I thought renal infarction. You know what I mean? But you get the test, you work them up. See, we have, okay, now the labs, of course, right? We're talking acute presentation here, emergent presentation sometimes. Get the labs, they start to not make any sense. Especially if you do have the renal tubular epithelial cells. Why? Do you have acute tubular necrosis here? Yeah, but only in this little part, right? See? The patient, this is not an ATN presentation, but they have renal tubular epithelial cells. That doesn't make any sense, right? That section of the kidney's dead, so all the shit's coming out, right? The renal tubular cells are dying because that part of the kidney is dying. Does that make sense? Yeah? But the patient's walking, talking, they're not like half dead. They're not hypovolemic. They have no other reason to have something like that. Leukocytosis, why? Inflammation, that's right. An inflammatory marker. CMP, electrolyte disturbances, why? Because part of the kidney's dead. Okay? LDH, you guys remember that? LDH, lactate dehydrogenase. increase, lactate increase, right? Okay. And BUN and creatinine. So all these labs kind of make sense, but they have flank pain and fever only on one side. See what I mean? The labs and the radiographs will get you to this diagnosis. Now, how does that help you clinically or on an exam? This patient will probably have risk factors or will have atrial fibrillation. That is the most common setup, okay? And then here, CT is gonna help us, all right? And then, echo, if this patient has a atrial fibrillation, they've thrown a clot into their kidneys, there's a good chance there's a big nugget sitting in there that's breaking off pieces, and so we need to find it and get it out. But this is not the heart class, it's kidney class. Okay, and so again, don't worry about this stuff as far as just understand anticoagulation and revascularization as necessary, okay? Potentially partial nephrectomy. All right? And then afterwards, I told you, ACE and ARB is always on there. But again, if I want to put a bow on renal artery renal infarction, AFib, clots thrown, labs look funny, present as chronic kidney disease, but with tubular epithelial cells, flank pain, fever, back pain, maybe, CT shows infarction, right? That's really what you need to know about that. Renal vein thrombosis, which one of the nephrotic syndrome did I say that really likes to form renal vein thrombosis? Membranous nephropathy, the adult one, okay? Any of them can. Membranous nephropathy, for some reason, has a higher incidence of it happening, okay? Adults do worse with things than kids do when you talk about kidney stuff. So more sequelae generally, all right? Nausea, vomiting, flank pain. Looks just like renal infarction, looks just like kidney stone or pyelonephritis. What's the answer here? Oh, CT scan, right? It's going to show a big thing in the renal vein that doesn't belong there, okay? Same. And then anticoagulation, and again, this would be the big one. If the patient doesn't have nephrotic syndrome, and you all learn this in heme, the hypercoagulable states, if you have this patient who's formed a thrombus idiopathically in some weird site, now it's time to send them to heme to see what kind of weirdo hypercoagulable state they have, right? Okay. Any questions about those things? No? All right. I'm going to buzz through these and then see where you guys are at. Here we got one more. Renal cystic disease. Again, it's going to be right down the middle, y'all, because it's easy to identify, and when you find it, send it. Okay? Other, right? Plasma cell myeloma, you're going to learn about that in the, I'm not going to have questions about plasma cell myeloma kidney. All right, this is a prelude for you for that lecture in ONC. But just understand, you remember me talking about the serum protein electrophoresis and the urinary protein electrophoresis, where you have that bump at the end because the body is way overproducing a certain IG, right? IG blank. Usually it's IgG, but anyway, right? You remember the IGs, IgA, IgE, IgM, right? Immunoglobulin, all right? So plasma cell is an undifferentiated cell, B cell, right? That's what creates the immunoglobulins. If one goes awry, which it does, basically have this huge overproduction of an immunoglobulin. You remember what an immunoglobulin looks like, the little Y with the extra little pieces on the outside? Right, the little pieces on the outside are the light chains. Heavy chain, light chain, okay? So, if you have way too many of those things, the kidney usually filters them. No problem. We have way too many overproduction, now they get stuck in the kidney, they get gummed up. Remember, like I was saying, gummed up that works like myoglobin? in rhabdomyolysis. It's very similar, just something else, okay? And that has a direct nephrotoxicity, and it causes a sharp decrease in glomerular filtration rate, okay? So, plasma cell myeloma, that's light chain castor. You will see this exact slide in your onc lecture. I just wanted to bring it up because it has to do with the kidneys, okay? And again, cast form, light chain cast, or they just completely block it up and cause non-functioning nephrons, causes sharp decline in EGFR. Sickle cell, did you guys talk about that already? Good, then you might have actually already seen this slide, right? If you have microvascular damage because you have crescent moon-shaped cells instead of deformable biconcave cells like you're supposed to, they get stuck and they cause a vaso-occlusive crisis, right? So you know that, we all know that? In hemolytic anemia, right, we have this overwhelming influx of hemoglobin as well. So we have a dual hit on the kidneys. All right, good, you guys have already seen this. No reason to pay attention to this too much. All right, did you talk about the 2,3 DPG and oxygen dissociation curve? Yeah. Because anyway, oxygen has an affinity, has come off in a more acidic environment like the vasorecta, and so it's just a whole thing. It's just a whole thing, you guys. Anyway, sickle cell nephropathy is bad. Okay. What's the treatment for sickle cell? What's the treatment for sickle cell trait? Drink water. Drink water. Right? All services screen for sickle cell trait now because you can precipitate a sickle crisis even in somebody that only has trait, especially at altitude or with severe strenuous exercise. The reason why we all are screened for sickle cell trait now is because of the United States Marine Corps. All right? So, and then sickle cell disease, what's one of the treatments for it? Huh? Who? Splenectomy, potentially. What's the medicine we can give to prevent sickle crisis or prevent reduction of sickle crisis? Isn't it hydroxyurea? Isn't that one? Is that ring a bell? No? Okay, never mind then. Leave me alone. Then forget it. Erase that strike that from the record.
I'll try.
Okay. Gout in the kidney, all right? Urate neuropathy, like we just have too many kidneys. And really, ultimately, what do you guys think that urate nephropathy manifests as? A lot of stones. Yeah, uric acid stones. And everybody puts hyperuricemia with gout, but let's not forget that if you have tumor lysis syndrome, which you guys haven't learned about yet, but here's prelude to that, you have a very metabolically active high cell turnover tumor, neoplasm. You hit it with chemotherapy, what does it do? Dies. The cells break apart. Now you have all this cellular material released. One of the things is the nuclear material, right? Which becomes uric acid, right? Hyperuricemia. And then last but not least, horseshoe kidney. How will you know a patient has horseshoe kidney? You will get a study of the albumin for something else, and you will find that the kidney is in the shape of a horseshoe. Because generally these patients don't have any other comorbidities. Their kidney does just fine. There's no reason to go cut it apart. There are very few reasons to go cut it apart. Okay? Usually the patient does just fine. They don't have any more or higher predilection for chronic kidney disease than anybody that has two kidneys. So you find it incidentally. And it can be, horseshoe kidney, this is the most common. It can be fused all together. It can be fused at the top, so it'd be like upside down horseshoe kidney. But really doesn't matter. Now, if you get it and you find it in a patient and you want to send it on to the nephrologist just so they're on their service, that's perfectly fine. Or you can just give them a call and say, hey, I got this patient, labs are all normal, I found horseshoe kidney. They'll probably say awesome or neat, right? And that's about it. So, any questions about this stuff? All right. So it's about break time anyway. Why don't you want to just take 10 minutes, come back a little early, and then we'll knock this out? Okay, let's do that. Increases hemoglobin F to reduce sickling, right? Yeah?
We just haven't studied that.
You ever got to sickle cell disease
We
yet?
had it, we just aren't studying for it right now.
Ah,
It's not the next
Break
one.
up the-
gotcha, gotcha. All right. Focus, here we go. So, we didn't talk about, we didn't have cancer on our review today, but how do you find most renal cancer? Incidentally, looking for something else, right? And what does it look like? What is the radiologist going to tell you? Simply, huh? Okay, a mass, but what specifically about that mass? Solid mass. A solid renal mass, that's cancer until we figure out otherwise, right? Now we're talking about cystic disease, okay? With simple renal cysts, they're nothing burger. They're mostly an incidental finding, and you can let them go if they're one or two. There is a definition of how many are too many, but just you can understand that if you see a simple renal cyst, that is something that doesn't have to be followed. It doesn't indicate kidney disease, all right? So it's just a cyst, just like a cyst anywhere else in the body. There's an epithelium-lined cavity with fluid in the middle, okay? If you guys are doing your renal ultrasound practice, when you do ultrasound stuff with emergency medicine, likely one of you is gonna have one, maybe even more. It's a common finding, and it really is incidentaloma. Have you ever heard that word before? We find it, and it's like, okay, great, I also have that. A simple renal cyst. There are specific criteria for what makes a simple cyst versus a complex cyst, and then of course then we have a solid mass, which we already know about. Incidentally, fluid filled, usually patient doesn't have any symptoms, right? You just have this little thing on the kidney. Now this person doesn't have their kidney anymore because it's outside, but like when it was inside, that wasn't causing them any problems. It's just a little bump on the kidney. Right? The only reason it would ever cause if it gets large and it bursts or ruptures, then it can get infected, it can bleed, stuff like that. But the overwhelming majority, 99.99% of simple renal cysts cause no symptoms whatsoever. Patients never know they have them, and they never would have known unless we had irradiated their midsection and found it, right? Yes?
How likely are they to rupture?
But not really likely, honestly. Not unless they're huge or there is a bunch of them. So like when we talk about autosomal polycystic kidney disease and their overwhelming mass, that's really likely that there's going to be a rupture. These, unlikely, and even if they do, a lot of times it doesn't matter. Nothing happens, right? So the likelihood is pretty low that they actually rupture. Unless they have a real big one on that, like that one on the bottom there, more likely if the patient gets get hit at the side or something like that. But not super common, frankly. Okay? So it happens, it can happen, it's a theoretical risk, but I mean, I'm telling you more often than, so much more often than not, nothing. Patients would never know that they were there, okay? The biggest thing is to differentiate and make sure. And the radiographic findings are what's gonna really tell you, okay? The radiologist report is gonna tell you, hopefully, in depth what it actually is. And if they're doing their job, it should give you this precise verbiage that tells you that this is okay. If it doesn't, or if they pull one of the radiologist crap, like doesn't correlate clinically, then you probably have to work it up further. But if they do their job, it's good, it's nothing, okay? So this is what it should look like if you get an ultrasound. Anechoic, right? What does that mean? It means there's nothing in it. It means the ultrasound wave goes all the way through and comes all the way back, it doesn't bounce off anything, all right? Sharply demarcated walls, right? So it is a distinct circle. And you can see the back, but there's nothing there, all right? Does that make sense? So if it's a dark black circle on a kidney, on an ultrasound, that is perfectly fine. That's reassuring. Okay? CT scans, very similar. Should enhance, if you do a contrast enhanced CT, there should not be any uptake of the contrast within the cyst itself. If there is, that means it's metabolically active. It could be an infection or it could be a complicated cyst. All right? If it's just a fluid-filled sac, it should just be another black circle on an ultrasound, or on a CT scan, okay? If it is inconsistent with that, if it doesn't say those things, if it's not, sometimes the radiologists, again, if they're doing their job, will say, simple renal cyst. Fine, leave it alone. You don't have to do anything else with it. You don't have to follow this patient. You don't have to get repeat ultrasounds at a time interval. You don't have to do anything else ever. Guess what? You have a simple renal cyst. It's not going to cause you any problems. Cool, right? That's it. Does that make sense? No follow-up, no nothing, no active surveillance, no watchful waiting, nothing. If it's anything other than that, if it's loculated, right? If there's stuff in it, if there's too many of them, then refer that on to urology because they might need a piece of it or a biopsy or see what's going on, okay? So basically, if it's not consistent with those specific criteria that we had in the past few slides, it might be worth your while to send it on, okay? Does that make sense? So, now, polycystic kidney disease. Those are not from a horse, those are from a person. Those are from a people, all right? Sorry, coffee. All right, so anyway, most common things can still be rare. Okay, does that make sense? The most common inherited renal cystic disease still doesn't mean you're going to see it. Most likely you won't, but you're going to see it on the pants. You see it on my test. It's easy. Okay? How do you think you diagnose this? Just guess. Ultrasound. Ultrasound shows blown out kidneys that have a ton of renal cysts in them. Okay? What might be the other way that you diagnose this? Family member, that's a good thought. Incidentally, but how? Hematuria or proteinuria. Again, unexplained persistent hematuria or proteinuria might be the first manifestation of something like this. Family history, definitely. What if you have an adopted patient or somebody who doesn't know their family history, right? So yeah, all correct answers. Usually we stumble upon this. Now, if we have a family that we know has this in their history, they will do genetic testing. That should be done already. If it's not, then, if we have this in our family history, then obviously that just goes right to the top, right? But incidentally, hematuria, proteinuria, cysts on an ultrasound, flank pain, unexplained, whatever, right? We usually chase it down and stumble on it. We don't go chasing after this unless we know the patient has a family history of it. Presentation, classically, microscopic or gross hematuria, all right? Flank pain or abdominal pain if it gets really big, and I mean these things can get really big, you know what I mean? But you might actually have renal megaly, maybe have a palpable renal mass. These are very tense and very large, so these are more likely to rupture and then cause bleeding, more severe bleeding, or that infection, okay? They're also just more likely to get infected because there's just so many of them, okay? And then hypertension, just renal vascular hypertension, not renal vascular, like renal etiology of hypertension, because again, we're just losing nephron mass, just trying to get perfused to the kidney, it's not working. So the whole RAS system is just way off. And then clearly family history. So you see these, yeah, these ones are likely to burst. Like not anymore, but like when they were in the patient they were, okay? That's scale, I mean, think about that. If you have a football on either side, and this happens bilaterally, this isn't a unilateral disease. So again, what does this say? Initially, hematuria, proteinuria progressing to worse, high urine, bacteriuria as these burst or become infected, progressive loss of concentrated units. So we're getting towards intrinsic renal disease looking labs, right? EGFR is going down, BUN and creatinine are going up, the ability to concentrate urine is going away, the ability to maintain fluid and electrolyte balance is off, right? So just sharp decline to end-stage renal disease, okay? And ultrasound is the initial test. Now you do not have to know this. What you do have to know is if you get an ultrasound of the kidneys and there are more than a couple simple renal cysts in there, remember this part of the class and say there's a diagnostic criteria of how many are too many for a certain age and look it up. Okay? I don't remember that. I just remember the thing I just said. There's a cutoff where some is too many. I just need to look up and see what that criteria is. Because then you can say, all right, this patient might have ADPKD. I'm going to send him to nephrology, right? Okay. So I won't ask you how many in this age range. We're not going to make that differentiation. Not necessary to remember shit like that. Okay. Make sense? Okay. Yes.
So is the prevalence of benign cysts lower in the middle years than it is in the early years
No.
of life? 'Cause why does it go
No.
3?
Why does it go down? I mean, I don't know. I don't know why it goes down. I don't know why this is a criteria. I don't have a good answer for that, honestly. Right. Huh?
Doesn't it still go up? It's 3 total, and then 4 total, 2 in each, and then 4 in each, so it keeps going up with age. Like it doesn't go.
Yeah, I
down
mean,
until-
yeah, it goes up a little bit, so it's 4 total, 4 and 3. So, but again, why is this specific number the cutoff? I don't know. I guess they just say, that, you know, how many is too many? That's too many by research. I mean, this is a result of epidemiology. But yeah, you're right. You're right. The number does go up. So yeah. He thinks he's better than me. Why does my test say version B? Don't look.
I'm not wearing a name tape right now.
All right. So CT scan if you need it. Ultimately, I mean, renal cysts are going to be clearly identified on an ultrasound. I guess the only real reason to proceed to CT is if there are some findings that suggest maybe some are complicated or other. Because again, if you think about this, what is this? This is a progressive metaplasia, right? Differentiation, like overgrowth of these cells. What is a likely potential outcome if something becomes, you know, super metaplastic, like overgrowth, abnormal cells? Cancer is a potential outcome, right? Metaplasia can become dysplasia, right? Barrett's esophagitis, you guys remember that? That's why it's so important to keep an eye on that. Same thing, if we have this gross cellular turnover and the cells aren't forming correctly, the likelihood that one takes a left turn and becomes neoplastic is a possibility. So cancer is a possibility for this one too, although significantly less likely than what we've already discussed. Okay? Extrarenal manifestations, polycystic liver disease. I doubt you talked about that in GI, but it is a thing. Okay, so this patient, if they have this, you know, deformity in their kidneys, you know, defective collagen, it can go everywhere, essentially. Cerebral aneurysms are a potential, cardiac aneurysms, but the most likely manifestation outside the kidney is going to be polycystic liver disease. All right. How do you think that would present? Weirdo liver labs, exactly. Right? Yeah. Most likely AST, ALT elevations, I mean, potentially alk-phos elevations if you're obstruction in the biliary tract, which you can get, right? So weirdo liver labs plus weirdo kidney labs, something's going on, right? And how do you think you find polycystic liver disease? You stumble on it, right? You know, you probably see this patient has weirdo liver labs, get an ultrasound of the hepatic ultrasound, which is your next step from weirdo liver labs, and you find this, and you're like, oh shit, all right? Right? Or eureka is what you should say. Like, look what I found. I knew it. I knew this patient had polycystic liver disease. You're like, really? No, I did not. So, early detection and management. So, genetic screening, and then also, again, the whole standard theme that we've been talking about the entire time, not letting unexplained hematuria and proteinuria walk out the door without figuring out why. Because we can't, the goal here is to extend this patient's kidney life as long as possible, because this patient is progressing to end-stage renal disease and renal replacement therapy. Okay? There is no stopping this disease. There is no cure. There is no reversing the damage that's already been done. There is only allowing them to keep their original kidneys for as long as we can. Yes?
When this diagnosis is made, do they immediately get put on like a transfer list, or do they?
No, not until their GFR declines to a certain threshold. Okay? Because they, I mean, depending on where that, I mean, it's depending on the diagnosis. But if their GFR isn't, you know, if they're still in the 80s, 90s, which they very well might be, you know, they're not an immediate need. You know what I mean? Even though it's going to happen. And then the kidneys that they do get don't make this transformation because they're somebody else's, and so they do okay after renal replacement, all right? And then also, again, you know, once they get to a certain threshold, you know, dialysis is still a potential for them, you know what I mean? So, and again, what are we going to avoid? Like in our milieu, right? Nephrotoxicity. No NSAIDs for this patient, right? Tell them to avoid dehydration, those kind of things. Simple things. Stop smoking, reduce your risk of cancer anyway. We already talked about, it's always on there, man. ACE or not. Okay. Complications shouldn't be anything that you probably couldn't come up with, right? If they have renal megaly and have this huge kidney taking up space in their gut, they're gonna have abdominal pain, and renal pain, and flank pain. Sometimes they get stones, as a matter of fact, right? They have a decreased ability to reabsorb calcium, so the calcium stays in the tubular filtrate, so this patient can have stones, all right? Hematuria, ruptured cyst, or just a lack of appropriate glomerular permeability, and then infection as these cysts just either become static fluid, become so large that they infect or rupture and then infect. So nothing super magical about that. Nephrolithiasis, don't focus on the treatment here because we're going to talk about it later, but ultimately the main treatment for nephrolithiasis is drink water, lots of it, right? And then screening arteriography if you have somebody who has a high-risk profession and they have ADPKD, because they can develop cerebral aneurysms. But again, cerebral aneurysms are a lower risk. And so this isn't globally, everybody doesn't get a CTA of their brain, but some people, certain populations will. Don't worry about that too much, all right? And ultimately, this is slowing disease progression. This is all we're doing. Slowing disease progression, avoiding nephrotoxins, avoiding diuretics and dehydration, maintaining kidney life as long as we can with ACE and ARB at maximum tolerated doses, and then they're going to end-stage renal disease. This is 50% by age 60, 100% most likely, right? Almost all of these patients will end up with renal replacement therapy if they live long enough. Most will need it before they're 60 years old, is what that's saying, all right? Most of the questions are going to come off this, so this is why I don't ask you to memorize these permutations, because it's dumb to even try to commit something like this to memory, all right? So just understand there's a threshold of how many is too many, and if you're unsure, look it up and then take it from there, okay? Questions about that? Yes? Oh, no, okay. All right. MSK, medullary sponge kidney, even more weirdo, all right? This one, less likely, does not, this one, the patient will keep their renal function. It doesn't typically progress to end-stage renal disease. It is also found incidentally, and the most common way we find this one is a patient that we're working up for chronic kidney stones. So stones are more likely and more common on this side of the house. So medullary sponge kidney, you guys know where the renal medulla is, right? And it looks like spongy material in that renal medulla, right here, okay? So normal, right? And then we have all this spongy stuff. All of this represents tiny little cysts, okay? And you can see transposed against the normal kidney, it's not grossly enlarged. So we don't have that huge deformity like we have a renomegaly that we have with ADPKD. So again, this patient is likely to maintain normal, near normal renal function, okay? And again, it presents not, again, as a particular renal disease other than kidney stones or our old friend, hematuria. Yet another reason to work up hematuria and proteinuria. Yes?
Is the hematuria from the stones or from something inherent?
It can be both. I mean, it's more like, the hematuria itself would be a sequela of the stones. The stones are a sequela of the disease. So if you want to chase that dog, I would say or walk that dog, it's because of the disease. Yeah. And it's most likely, because they can have hematuria without the stones, right? And again, the hematuria and the stones, if we want to continue that thought process, like most of the bleeding that you're going to get from a stone is extrarenal. It's going to start tearing apart the mucosa within the urethra, the collecting system. So the true hematuria as a result of this disease would be because of the cyst formation. Yeah. Yep, no problem. And again, maybe not with this one here, but most labs are going to kind of look normal-ish, except for the hematuria, all right? Likelihood that, decreased concentrating ability, it's not really going to be common. So labs are going to look normal to normal-ish, okay? But what you might see is just a burden, a stone burden Like all of these, I don't know how well you can see it up here, but you know, you see like sort of a kidney-shaped outline. All these represent tiny little kidney stones within the renal medulla. Okay. CTU will be our friend here again, most likely. Because they're not gonna have that gross renomegalomy, we're not gonna see much on, you know, when we look at this on an ultrasound, it's not gonna be these simple big renal cysts that look like black dots in the kidney. You're not gonna see much. What you will see is an echogenicity of the stones themselves. Like, holy shit, this guy has a lot of stones. So then we'll get the CT to work it up, see more stones, and then CTU say, what the hell's going on, okay? Does that make sense? Again, a lot of these diseases you sort of stumble on. Medullary sponge kidney is not gonna be at the top of anybody's differential diagnosis, all right? Again, it all stems from working that hematuria up or chasing down why does this patient keep having kidney stones. Okay, well-maintained, right? Well-maintained renal function. No specific therapy, right? Not even really an HNR. This patient's not spilling protein most likely. This patient's GFR is okay. Like, so this is different, and there's a contrast to ADPKD here, right? They're keeping their renal function, so they don't need to start an ACE or an ARB any sooner than any normal patient. Does that make sense? Okay. You'll keep an eye on them closer. Like, we will follow these patients. These patients will be seen by nephrology every year. When they come and see us, and you have that in their patient history, we'll keep a sharp eye on their urinalysis and their CMP, but it doesn't necessitate any kind of specific earlier therapy, unlike the other disease, right? Okay? And then, last but not least, acquired cystic renal disease. This is a patient who gets cysts from dialysis, so they have bigger problems. Anyway, any questions for me? That is all for today. I will see you all on Friday after your exam. Good luck on your EMED exam, and see you later.